I want to get clear on something because I've heard people talking on my podcast before about HRT
Yeah.
and women taking HRT because of menopause and things like that. Does HRT have testosterone in it?
No. So typically when we say HRT, we're talking about estrogen and progesterone, typically.
Yeah.
And typically when we talk about TRT, testosterone replacement therapy, it's a little bit different. In a woman, there's something I call the triangle. And it's just basically estrogen, progesterone, and testosterone. Just simple. And if you have a woman who's deplete in estrogen, testosterone, and estrogen, progesterone, testosterone, and replace it, many of those women feel better, right? So many of them do. There are other hormones that are also important. I call it the outside circle: cortisol, thyroid, growth hormone. We look at those as well. And so I think those are also very important. And I tell them, we're going to optimize your hormones, but we're going to optimize your medical condition, but that is only 50% of the story. The other 50%, again, is diet, exercise, sleep, and stress reduction. And if you do your part, and I do my part, we're on fire. We're absolutely on fire, but you have to do your part. Same with men. I put you on the testosterone. I optimize your medical conditions. But you gotta exercise, you gotta eat right.
But why aren't women being prescribed testosterone then?
Right, because it's considered, well, in many countries, in Australia it's available, in the UK it was available, and many women are being prescribed testosterone.
Okay.
It's just off-label.
It is the first time that I've seen someone, on my show anyway, really emphasize the point that testosterone isn't just for men, it's for women as well.
And it can significantly improve their quality of life.
Talking about testosterone, one of the big conversations that's rattling on the internet is about this decline in male testosterone over the last couple of years. What exactly is that decline, if you had to sort of quantify it?
If you look at the original studies, we call it the Framingham Heart Study back in the 70s, testosterone levels were roughly around the 700s. Average men between the ages of 18 and 40 were around the 700s. And every decade, we're starting to see a decline almost by 50 nanogram per deciliter. And so the latest, in the 2015 numbers, are roughly in the mid 400s. So we've seen almost a 300 nanogram per deciliter decline in serum testosterone, which is significant because it has two implications. It's not just about the way you feel and energy, muscle mass, erectile function, but that low testosterone can have implications on fertility. That's really important. So we didn't talk about that, but fertility, sperm need testosterone. Low testosterone decreases your sperm count. Sperm counts have also been on the decline as well. So, I think it's really a testament to the fact that decade by decade, we're becoming a more unhealthy population.
Do you think that's really the heart of it? Is this sort of our diets and the way we live and becoming more sedentary, less exercise, more processed food, etc.? Do you think that's the heart of it?
I think that's the key. That's absolutely the key. The types of foods we eat, the processed foods that we eat, high fructose, high carbohydrate diets, and the way we know that is just look at the obesity, look at the diabetes. There has to be a reason why it's on the rise, right?
And on that point of fertility, I'm in a season of life where I'm going to be trying to have kids pretty soon. What's the most important things I should be thinking about from a lifestyle perspective in your view?
Yeah, so I tell patients Darwinism, in other words, survival of the fittest. Healthier people are more fertile, right? You're passing on the genes. So essentially, we tell patients the number one cause of infertility in the world for men is a varicocele. A varicocele is the swelling of the veins around the testicle. You know how women sometimes can get swelling of the veins in their legs? You see those veins that are kind of obvious? Well, men can get those veins dilated around the testicle, and those varicoceles can impair sperm production. Now, 15% of men in the world walk around with varicoceles, but up to 40% of men with infertility will have varicoceles. So it's really important to assess for the varicoceles. But lifestyle modification, each one again, diet, exercise, sleep, have been shown to help improve fertility in men as well. So I say healthier people are more fertile. I need you to start getting healthier. That's very important. We raise the testosterone level in many of these men naturally. We don't give it to them to help improve their fertility as well. But check your semen analysis. That's the simplest thing you can do. Check it. Right?
I did that.
Yeah. It's a great predictor. It's not just, there was so many amazing studies showing that a semen analysis is a phenomenal predictor of overall health. Many studies showing that if your semen analysis today is impaired, it's a predictor of you having comorbid conditions today like diabetes, obesity, metabolic syndrome. It's also a predictor of cancer. So we know that if you have infertility, you're at a higher risk of having testicular cancer than those that don't have infertility. And it's also a predictor of who will have problems in the future. Mike Eisenberg once showed a very nice study Men who have low sperm counts can have a 30% increased risk in diabetes, 50% increased risk in ischemic heart disease in the future. Tom Walsh showed those men can have 2.5 times higher risk of high-grade prostate cancer in the future. So again, to me, it's just a marker of overall health. Check the semen analysis.
I did that, and it was I was actually, to be honest, I was really quite nervous about it, because as someone who's in my early 30s and wants to have kids, I was really scared that it would come back and say that like my sperm is dysfunctional, and I've got a huge amount of empathy and feelings for people that do those analyses and get bad results back.
15% of all couples in the world, 15% suffer from infertility. That's a lot. And if you think about it, 30% of the time it's a male factor, 30%. 20% of the time it's a male and a female factor combined. So indirectly, a male is involved 50% of the time when you have an infertile couple. And it can be devastating for that couple. I mean, psychologically devastating. And what's also interesting is that most couples, 50% of couples don't seek therapy. And of those couples that do seek therapy, this is globally, only 25% of those couples actually go forward. And so I call this a group of individuals that also suffer in silence. They should know that there are excellent treatment options available.
This graph that I had printed out is just shocking to me. It's going back to the point about testosterone, but the really shocking thing is how quickly this has happened. Yeah. Because this is the year 2000, and this is the year 2015-16, yeah. And the decline there is from roughly 600 nanograms, is it?
Yes, nanogram per deciliter.
Nanogram per deciliter to roughly, for some age groups here, 400 nanograms per deciliter. And that's only in 16 years.
Yes.
So if you play that forward another 16 years, there's going to be a bit of an infertility crisis.
There is. Fortunately, on that graph, it's plateauing a little bit, which makes me feel a little comfortable.
Okay. Oh, yeah, it is actually.
It's plateauing just a little bit, but you're right. It could be a significant crisis. And again, as I mentioned, it's the adolescents, the younger folks, who are having the greatest rise of obesity. And that's where fertility comes in. Because obesity in someone in 60s is not concerned about fertility, but a young patient who has obesity will have a higher risk of infertility.
If you're an entrepreneur, you're probably going to want to listen to this. It's a message from one of our sponsors on this podcast, which is LinkedIn. If you've listened to me on this podcast for a while now, you'll know that I've been on a bit of an evolution as a business owner and entrepreneur. And one of those evolutions that has become clearer and clearer as I've matured is that the single most important thing in building a business, in building a company, is hiring. The definition of the word company is actually group of people. And that is the first responsibility and job that any entrepreneur has and should focus on. But surprisingly, most don't. About 80% of my team have been hired from LinkedIn. And I think there's very few platforms, if any, in the world that could give you that diversity of candidate with that much information and data on their profiles. It usually costs money, but for the entrepreneurs that are listening to me, I've got you a free job ad post for your company on LinkedIn. Just go to linkedin.com/DOAC to post your free job ad today. That's linkedin.com/DOAC. Terms and conditions apply. If me and my partner came to you and we said, listen, we've got sexual problems in the bedroom, what are the steps that the things you'd look at that we haven't focused on so much today? Is there anything particularly you'd say, okay, and I'm trying to stay away from being prescribed a pill, so I want to do anything natural I can before I get to that, and then we'll talk about some of the other more drastic measures one can take.
So let's talk about natural things, because everyone wants to know about what's the natural things I can do. So when we talk about diet, there's certain diets that have been helpful to improve sexual function. For me, it's the Mediterranean diet. The Mediterranean diet is rich in whole grains, legumes, fruits, vegetables. And if you look at red meat and sweets, it's once a month. If you look at poultry, it's maybe once a week, but mainly fish. Those diets have typically been anti-inflammatory diets. Many studies have shown that diet can significantly improve erectile function. And one study, the Medita trial, actually showed that it improves sexual function in men and women. So I'm a big believer in using the Mediterranean diet. When Esposito did her first trial, it was a prospective trial, 110 obese men. 55 men get the Mediterranean diet. 55 men don't get any intervention at all. She follows them prospectively for 2 years. What does she find? Not only a significant improvement in endothelial function, remember that lining of the blood vessel, but a significant improvement in erectile function in these men. No Viagra, no pills, nothing. Simply changing the diet improved the erectile function. And the same with sexual function in women. So that's an important one. The second is sleep. Let's talk about sleep. So studies show that if you're getting less than 6 hours of sleep a night, it significantly increases your risk for sexual dysfunction in men and women, right? Your ideal amount of sleep should be 7 to 8 hours. Now, let's say you say, well, that makes sense. Maybe I'm going to get sleep for 9 to 10 hours because the more sleep I get, the better my sexual function. But that's not true. It plateaus. So if I'm above 9 hours, it does not increase your ability or sexual function. So 7 to 8 hours of sleep a night, I need you to get. Third is I really need you to focus on exercise. So I published a very nice study looking at, it was a meta-analysis on how much exercise one needs and what type of exercise to actually improve erectile function. In this study, typically you need 160 minutes a week, so 40 minutes 4 times a week for a course of 6 months of moderate to severe exercise, vigorous exercise. And so most people can get 160 minutes in a week of exercise, but that's getting your heart rate up and doing the exercise. Significantly improved erectile function in men if you did that. And the more severe your ED was, the greater improvement you saw in erectile function strictly by exercise alone. No other intervention, Stephen, just exercise. So here you have a patient that now starts doing some exercise, starts sleeping better, starts changing the diet. It's all additive. You are now significantly improving erectile function just by lifestyle modification alone.
Pretty profound that exercise can have such a big impact, isn't it? Is that the same for women?
It is true because many of the things. So unfortunately, once again, the research we have in women is not close to what we have in men. But the MedEda trial was also in women. The sleep studies were also in women. And so these studies also show that sexual function can be improved with sleep and with diet. I think that men and women are not that different. I mean, if you see a significant improvement in a male sexual function with diet, exercise, sleep, you can also see it in women as well. Actually, there was a great study. This looked at 110 women, and they had coronary artery stenosis. They did angiograms on 110 women, and they showed that the greater her stenosis she had, the worse her sexual function. So the greater the blockage in her heart, the worse her sexual function. They put those women on a cardiac rehab program to actually improve their cardiac function. So a diet and exercise program. And those women that actually were through the program, 4-fold increase almost in their sexual function.
What, 400%?
4-fold. Yes, sorry, because we use a questionnaire called the FSFI, which is a questionnaire. So a significant improvement in sexual function just on improving cardiac function. So remember, cardiac function and sexual function are related. And it's bidirectional. You improve one, you improve the other. It's very important. We talked about this earlier. 40% of men in the world at 40 will suffer from erectile dysfunction.
40%?
40%.
Jesus.
50% at 50. 60% at 60, 70 at 70, 80 at 80. You do the math. It essentially is a very prevalent condition. This condition is associated with increased cardiovascular events. It's the first sign of a heart attack. We talked about that. This condition is associated with 2.5 times more likely to be anxious, 3.5 times more likely to suffer from depression. And this condition is also associated with diabetes. In other words, men with ED, 2 times more likely to have undiagnosed diabetes. And yet, only 50% of men even talk about it because they're so embarrassed. So you show me another condition in the world that affects more men's lives, that's associated with more adverse conditions, and they're too embarrassed to speak about it. They suffer in silence. There's not another condition. There's not another condition, but yet we're embarrassed to discuss it. I used to give these lectures, and I would look out to the audience. I'd say, please raise your hand if you suffer from hypertension. And many people raise their hand, they have high blood pressure. I'd say, okay, please raise your hand if you suffer from sexual dysfunction. No hands go up. But statistically, you know that over 50% of those people had sexual dysfunction. So why is it okay to raise your hand if you have hypertension, but not okay to raise your hand if you have sexual dysfunction? It's got to stop. We have to destigmatize. It's okay to have sexual dysfunction. It's a common condition. It's curable.
Why don't men raise their hands from a psychological standpoint? Why is that?
I think they're embarrassed.
Why?
I think that historically sexual dysfunction looks as like a weakness. I'm not a man, less of a man. Mm-hmm. You know, you have hypertension, it doesn't mean you're less of a man, right? But they have this assumption that it's a weakness, less of a man. And I think that it's okay. You have to be comfortable saying that you have sexual dysfunction. There are amazing treatment options for sexual dysfunction, amazing, that work very, very well. You just have to raise your hand and let me know that you have it. I just want to make one other comment about diabetes. There was a study that came out of St. Louis looking at young men, 18 to 40 years old, and they were screening them for erectile dysfunction. And what they found was when those men came in for erectile dysfunction, 30% of those men had prediabetes or diabetes on that day, on the day they were being diagnosed, 30%. Wow. And I thought to myself, young men do not go get screened. I remember when I was 30 years old, I didn't go in for my annual blood pressure check and my annual sugar check. There's no way I'd get my glucose checked. But if a young man gets erectile dysfunction, he is at my front door first thing tomorrow morning. They show up. It's the first thing they're gonna do because it's a very big condition to them and they wanna get treated. And that is the opportunity to treat these young men and treat the condition. If you see a young man or someone who comes in for ED and you screen them for diabetes, and I catch the diabetes at 30 as opposed to 40, that is 10 years of damage on the vessels that you're saving because you catch the disease early. So ED is the gateway to men's health and to treating men early before it's too late. So I really use sexual health as a tool, a vehicle to improve overall health, because men take sexual health much more seriously, particularly young men.
Have you ever had sexual dysfunction?
I have not.
Never in your life?
I have not.
I have.
I have not.
I've been in
but
situations where
it doesn't mean that it's not.
Yeah.
But it's okay if I did. It's not. There's nothing wrong with it. Right? There's nothing. It's normal. It's okay, and it's transient. It can be temporary and come back. Right? It's nothing wrong with having sexual dysfunction. We must destigmatize it. It's completely okay.
The reason I'm sharing this is because if anyone else has been in the situations I've been in are generally my sex life has been good my whole life, but there's been certain times with certain partners, or you might be drunk a little bit, or in the day when I was single, there was like the odd person who for some reason it just wasn't working for me, or there was other instances in a previous relationship where near the end of the relationship I'd like lose my erection during sex, and that became a little bit bothersome for me because I was like, oh my God, it's like it almost made me not want to have sex with this person, or it convinced me that maybe I don't like them anymore, or something else was going on. And for me, it has always been, what's the word you use, psychogenic?
Yes.
It's always been in my head that the problems have arose. And the other part of the thing that I've experienced a lot is in terms of libido, I have like no libido when, actually it's slightly different. When work is very, very busy and I'm very, very tired and I come home very, very late, it's not that I'm not horny, but the act of sex is just really unappealing.
But you're just like everyone else. You're not unique when it comes to that.
Yeah, but that much of my life is like that. Like I come home late a lot, and so I'm like tired and stressed quite a lot.
Right, but what if I took you and your partner and put you on a beautiful island in Hawaii for 2 weeks?
Oh, we have great sex.
Okay.
Yeah, so that's what we're kind of like how we've orientated our life, honestly.
Okay.
No, that's genuinely how we've orientated our life, because I just don't think the way, I obviously want to make lifestyle changes to make sure that I'm not always coming home tired and stressed at 11 p.m. But one of the things that's really helped us is, going away on the weekends.
Right.
And going away maybe on Friday and coming back on Monday, and getting out of the same context. So like getting out of the house and going to going to a hotel room. It's actually a bit of a game changer that you can just like go to a hotel room in the same city, like book a staycation.
Yes.
And that seems to have a big impact because it just removes you from the context.
Right. And
then going away for the weekends, holidays and stuff. A lot of my friends say to me, they go, when they're struggling with their sex life, they just like book a local sort of staycation.
Yeah.
And I wonder I don't have kids, so I've not experienced the impact that kids can have on libido.
Which can have a significant impact.
Really?
Right, because it increases your stress. Right, okay. Particularly for many times for the partner as well. So if you both are stressed because of the children, sex goes lower and lower on the totem pole.
And underslept as well.
Right.
If you're not sleeping, if you're having to wake up and be like, oh gosh. Isn't there stats that say like when someone has a kid, their sex life like vanishes for 18 months or something?
I'm not familiar with that stat, but I believe it. I believe it. I
read something about post having a kid libido, but also just like sexual function.
It makes sense. I see it in couples, and particularly many times it can take years for them to start engaging sexually because the stress is so high, particularly when they originally have the child.
There was a British study done that found over 80% of women experience sexual problems 3 months postpartum, with nearly 2/3 still affected at 6 months.
Yes,
which is a lot of.
It's a lot of women.
A lot of women, and that's a significant amount of time. So. What about premature ejaculation?
Let's talk about it. Very important. So sexual dysfunction, we've been talking about ED today, right? But there are many different types of sexual dysfunction. There's premature ejaculation, there's Peyronie's disease, there's delayed ejaculation. We're just focusing on one aspect. Premature ejaculation affects 30 30% of men globally, 30% of
How
men.
do you define that?
There's two ways to think about it. When they come in, you have to figure out, is this lifelong, going their whole life, or is this acquired? It's very important because it takes me down two different roads. If you say, look, I've never had premature ejaculation and yesterday it started, that's very different than if you come to me and say, my whole life I had premature ejaculation. And we now define premature ejaculation as having an ejaculation less than 2 minutes. It used to be 1 minute, less than 2 minutes. You have to have a loss of control, like I couldn't control it, and you have to be bothered by it. So if you tell me, Stephen, look, I ejaculate in 30 seconds and I'm happy, I say, great, then we're done. You are content. You have to be bothered by the condition. The average ejaculatory time in the United States is 5.4 minutes on average, right? The average time for a woman to achieve orgasm is typically 13.4 minutes. So there's a big discrepancy here, as you can see, right? So 30% of men suffer, but we know that only a small percentage of these men, 9% of these men, will ever seek therapy. And it can be a significant problem in a relationship, and that needs to be addressed.
Okay, so there's not like a time limit. It's not like, okay, if you're coming within 2 minutes, then you've got a problem.
Well, let's say you're not bothered by it. Let's say you and your partner are completely satisfied with it. What's the problem?
Okay.
What's the problem? And sometimes, if you think about acquired, means that typically we define it as 50% less than your normal time. So if you say, look, I typically used to ejaculate in 8 minutes, and now it's 4 minutes, and it's bothering me. I'd say, okay, that's an issue. So we talk, it's relative. What's comfortable for you? And some men will say, so I think it's very important to look at the definition. The treatment options are actually quite simple. One of the best treatment options is sex therapy, because we can train your mind. We can train you to delay that ejaculation. There's techniques, the start-stop technique, the squeeze technique, how we can delay it. No, but there is. But most men say, just give me a pill. I don't have the time for this. Just give me a pill. But there are ways to do it with sex therapy, which I think are fantastic. Sex therapy is a cure. The pill is just a Band-Aid, right? Sex therapy is a cure. But the pills that we use, the most commonly used pills, are antidepressants because they increase serotonin and make it harder to ejaculate. Well, that's what we want in this situation. We want to delay the ejaculation. So we can use antidepressants. They sometimes have to be taken daily, which work better, or you may have to take it on demand. But if you take it on demand, 6 to 8 hours ahead of time. So you need some notice.
But there's going to be significant side effects of taking antidepressants.
Yeah, there are side effects of antidepressants. So I try to stay away from them. And the other ones I try to use are topical lidocaine sprays. Because if I decrease the sensitivity of the penis, you're more likely to be able to engage in sexual activity for a longer period of time. So those are commonly used. So sex therapy and sprays are very easy to use. You don't need a prescription for sprays, and they're commonly used. One thing that we have to talk about that's really important is the Traverse trial. It's really big. Everyone historically has always said that testosterone is dangerous. It causes prostate cancer, and it causes a heart attack and a stroke. And in 2015, there were some studies that suggested testosterone may cause a heart attack. Before 2015, all the studies suggested that there was no increased risk. So in the United States, they mandated that there be a large trial, 5,200 patients, 6 years long, strictly to decide, does testosterone increase the risk of a heart attack? So myself and 8 others designed the study, ran the study for 6 years, and we published it last year. It finally came out. And it showed that there was no significant increase in cardiovascular events, finally. But until that time, until that came out, many people said, I still believe that testosterone causes a heart attack. But when the Traverse trial came out, the largest randomized placebo-controlled trial ever published, we finally showed that giving testosterone did not increase the risk of a heart attack. In fact, the study also showed it did not increase the risk of prostate cancer. Many people were worried that testosterone causes prostate cancer, and no negative effect on urinary symptoms. So many people have thought that if I give testosterone, the urinary symptoms become worse. The study showed no worsening of urinary symptoms. So very important study. The Traverse trial finally came out. It's the largest trial in men ever published on testosterone.
Will it reduce my lifespan?
Low testosterone, I believe, will reduce your lifespan.
I mean, taking like testosterone injections and stuff. Sometimes I think about again, I don't really know what I'm talking about here, but I think about athletes taking steroids.
Different.
Okay.
Those athletes are taking supraphysiologic steroids. So the normal range is typically 300 to 1,000 is the normal range. And they will take testosterone levels to much higher, 2,000, 2,500.
Okay.
And there's a reason for that. There's something called a plateau effect. So if you take testosterone and you have better libido, you intuitively would think, if I take more testosterone, I'll feel even better libido. But that's not true. There's a certain point at which it plateaus. So the more you take, you've already hit an on-off button, you've hit it, you're done. The exception is muscle. The more testosterone your body sees, the more it upregulates androgen receptors in the muscle, and you put on more muscle. So bodybuilders are addicted to higher levels of testosterone, but they're also taking other off-label medications, Anavar, Deca, Winstrol. They're taking other medications, and those testosterone formulations have a lower androgenic ratio. Androgenic means facial hair, acne. They're more anabolic. So it's very different than what you're taking. You're simply, or what you would be taking, is just all you're trying to do is take a medication that you had before and put yourself back into the normal range. Nothing fancy.
So the more I've learned about testosterone, the more I've started to think that maybe when I've had my kids and I'm done having kids, and maybe I'm 45, I should consider it, providing that my levels are low.
And you're symptomatic. If
And
you're
I'm
45
symptomatic.
and you say, I feel great,
Yeah.
I'm gonna say, Steven, you're not getting it, right? I feel great. So if you say, look, I'm 45, my levels are low, and I'm starting to have symptoms, say, okay, now's the time to consider taking the medication.
Those symptoms you said were like tiredness, energy levels.
Well, the most specific are my libido's gone down,
Okay,
my
so
erections are
libido,
worse,
okay.
my energy's gone down, increased fat deposition, decreased muscle mass, poor sleep, and depression. And we have to talk about depression. So early on in my career, I conducted a very large trial looking at depression and testosterone. And we had almost 850 patients. And we showed that men with low testosterone levels were much more likely to suffer from depression. Almost 92% of those men with low testosterone had some degree of depression. And when we treated, 17% of those men actually had severe depression. We treated these men for 1 year with testosterone supplementation, and that 17% dropped down to 2%. Now, I'm not advocating to treat major depressive disorder with testosterone, but what I am advocating for is to at least check a testosterone level in men who are depressed, because it can help them. In fact, in our study, even the men who are on an antidepressant, like say Prozac, we put them on testosterone, those men also saw significant improvements in depression. So maybe some synergy between testosterone and what we call SSRIs. So again, it's very important to check a testosterone level in men who suffer from depression.
You wrote a book called Recoupling.
Yes.
A couple's 4-step guide to greater intimacy
Yes.
and better sex.
Yes.
What are the 4 steps in this book? And you wrote this alongside
Over 10 years ago, yes. So I wrote it with a sex therapist. She's an amazing sex therapist. Her name is Mary Jo Rapini. And we decided to write a book together to really help couples get through. So the 4 steps really are, number one, foremost, communication. You gotta communicate. You gotta at least be able to tell each other. Did you know that only 44% of men who start developing ED even tell their partners? Now think about that. You'd say, what do you mean they don't tell their partner? You know what they do? They just start avoiding sex. They just start avoiding sex. So they gotta communicate, number one.
And making excuses, right?
Yeah, I mean,
if I lost my erection, I'd probably say, oh, sorry, I'm just tired, or because I want to just, on this point, there's much of the reason why it's hard to communicate is because it can sound a lot like blame, and it also can make someone feel like you're not into them.
Right.
So if I said, and maybe you're not that into them, and also maybe you're not like that attracted to them. So like that could be,
that's
you
a
know what I
problem.
mean? Yeah.
That's an issue. And that's why the sex therapist is amazing.
Right.
That's what they do, right? That's what they do. They work through these issues with couples, and they're fantastic. But the number one step we put in the book was communication. You have to communicate. The second chapter was my main chapter, what I wrote about. What can we do to improve sexual dysfunction in men and women? Testosterone replacement therapy, using Viagra, vaginal lubrications, local vaginal estrogen therapy. We didn't talk about that. It's critical for postmenopausal women. Local vaginal estrogen therapy is very important. Decreases this risk of UTIs, decreases pain with intercourse. So very important. The third chapter really.
So what is that vaginal?
So younger women have estrogen in the vagina. That estrogen is so important. It keeps all the bad bacteria away and keeps the good bacteria within the vagina. It keeps the lining of the wall thick. It allows for the vaginal wall to function with arousal properly. And as she gets older and she goes through menopause, the estrogen goes away, the bad bacteria come in, the risk of urinary tract infections go up, the wall starts to atrophy, means it gets thinner. It's more susceptible to injury and tear. It hurts,
Okay.
right? So you can't ask a woman to enjoy sex if it hurts every time she has sex.
A lot of women, I've heard a lot of women talking about that, about this idea that the reason they don't like to have sex is because it hurts.
It hurts because when they lose the estrogen, the wall gets very thin and it can tear. It hurts.
But even young women.
Young women, but it's usually typically a different reason. They could suffer from vaginismus. There's other things that could cause vestibulitis. But in older women, the most common cause is atrophy of the vaginal wall because of the lack of estrogen. So what do? You give back local estrogen therapy. It can be in the form of a suppository, form of a cream. It doesn't happen overnight. I tell my patients it can take up to 3 months, but after 3 months, they notice a difference. And the urinary tract infections go away, the pain goes down, right? So these are simple things that women can do to help. Because again, if someone's having pain with intercourse, man or woman, they will tend to avoid it, right? It's an important concept. So the second chapter is really important on what are the many different things that you can do to improve your sexual function. The third chapter is really about intimacy. It's really the intimacy. And the fourth chapter really is ways to improve your sexual experience. It was written by my sex therapist. She talks about vibrators, masturbation. So there's a 4-step guide that I think is very helpful. And I think what's unique about this book is that really it's really 2 perspectives. It's one who is the medical care that I provide and the psychological care that she provides.
Now, she's obviously handling the psychological side of things and she's not here. But just on this point of improving communication, what is the best advice you'd give to people that are currently in a situation where they're both kind of suffering in silence because they're just not communicating with each other?
Number one, most important is time. We don't spend enough time. It's basically the shadows in the night. You coming in, I'm going out, and you have to make time. That's extremely important. And the second one is open dialogue. You have to be able to express to your partner what you're suffering from. Otherwise, you can't get treated. You just have to be able to express it. But time, I think, is important, and open communication and dialogue. There's nothing embarrassing about this. It really is something that needs to be destigmatized, and the consequences of addressing it. So couples who engage in regular sexual activity have a significant improvement in their quality of their relationship. They tend to be happier and suffer from less depression. I mean, there are physical and emotional benefits from regular sexual activity.
In the opener of the book where you start talking about communication, there's a sentence that says, when sex isn't going well, it can become 90% of the relationship, and couples seldom know how to communicate about any of these problems. And that is true. You know, we've done a couple of conversations now in the Diary about sex and intimacy and these subjects, and the amount of messages that I get from couples saying that everything else in their relationship is great.
Yeah.
Everything is great. Love this person so much, but there's this massive elephant in the room.
Right.
No pun intended, which is the lack of sexual intimacy. Now, when we talk about sexual intimacy, does it mean penetration?
Yeah, it doesn't. Because with the definition of sex span is the ability and the desire to engage in satisfying sexual activity. I have patients that come to me and say, we do not have penetrative sex, but we have a wonderful sex life. I say, great. If this is working for you because it's satisfying sexual activity, you're set, right? It's if you want penetrative sex and you cannot have it, then we will address it and we can fix it. But you get to define, Stephen, you define what is satisfying sexual activity.
On chapter 4, where you talk about things like vibrators and stuff like that, I know that was a chapter handled by your sex therapist, according to what you said. Is there any risk that using vibrators or other toys and tools will impact normal intimacy without vibrators? Like, is there any studies that say, okay, you get desensitized to the real thing if you start using a vibrator?
Yeah, I've seen the opposite. I've seen the studies showing that vibrators and these kinds of toys can actually enhance the ability of the relationship so that you can, because you're communicating as you're doing it, right? So you're communicating with your partner, what is giving me pleasure, what is not giving me pleasure. You're learning about each other. And it's a great tool to use to learn about each other. So when you're engaging in sexual activity, you're more aware.
I think it was a game changer for me. I'm going to be honest. I think like just having other things. Do you know why? It's a game changer? And I'm not just talking about vibrators. I'm talking about all toys in the bedroom, whether it's like dice or handcuffs or whether it's something else, a blindfold, is just because novelty, doing new things, for me is so critical as it relates to being excited sexually. And there's only so many things you can do. There's relatively limited list of things you could do if you're not bringing in other tools and toys and stuff, you know? So I think that for me, it actually has helped me to prolong the novelty of my sexual relationship in a way that nobody told me about before.
Yeah.
Because I think as a guy especially, I think you kind of think that toys are something your partner buys for herself maybe.
Yeah.
Something she uses for herself. And now I think if anything, I'm the instigator of using other things.
Yeah, that's chapter 4. I mean, and we prescribe vibrators for men. We use something called Vibrect. It helps with men with delayed orgasmia. These toys can be very helpful in a relationship.
I think she prefers the toys to me personally, but that's another conversation for another time. In terms of energy, there are so many reasons why I'm a big matcha fan, if you don't already know by now. And so much so that I actually invested in the UK's leading matcha company called Perfect Ted. And one of my favorite Perfect Ted products is these delicious matcha pouches that come in every flavor, from salted caramel to peach flavor to mint flavor to berry flavor. One of my favorites is this vanilla flavor, which I'm gonna make in just 2 seconds. You just take this mixer here, get a little bit of the powder, pop it on top of the shaker like that. Put the lid on. Shake, shake, shake. Delicious. If you haven't tried this yet, you can find Perfect Ted at Tesco and Holland Barrett stores or online, where you can get 40% off with my code Diary40. Head to perfectted.com and put in code Diary40 to try this delicious multi-flavored matcha now. Highly recommend. And if you do it, please tag me, send me a message online. What's the most important thing we haven't talked about that we should have?
Well, there's a couple of things I want to talk about. One is we didn't talk about Peyronie's disease. It's an important disease. 9% of men in the world suffer from Peyronie's disease. 9% of men in the world. Peyronie's disease is an abnormal curvature of the penis when it's erect. So I want you to think about this. The way I can describe it is if I have a balloon, I put a piece of tape on the balloon. I blow the balloon up. What's going to happen? It's going to curve in the direction of the tape, right? So if a penis curves greater than 60 degrees, it's prohibitive for intercourse. These men many of these men suffer from severe depression. It's disfigurement. It's disfigurement of the penis, right? So think about it. 9% of men in the world suffer from this condition, and most men have never even heard of what Peyronie's disease is. And essentially, in the US, we have now one FDA-approved treatment for this. It's an injection called collagenase, where we can put an injection into the rock plaque and break it up. There are surgeries that we can do to make the penis straight again. But again, it's very important to realize that patients who have Peyronie's disease are also suffering in silence. They don't know where to get the treatment. And there are many good treatment options, whether it be surgical or medical, to solve this condition. So, my whole takeaway from this is that I know that millions of people right now, men and women, are suffering from sexual dysfunction. I know they're silent and they're not saying a word because they don't know where to go. They don't know what to do. But they have to realize that there are excellent treatment options available, and they should seek therapy. They're not suffering alone.
What else?
I want you to think about sexual dysfunction as no longer a Band-Aid. We are not looking for Viagra. We are looking for a cure. We want a cure for ED. And a cure for ED can be based on many things, as I mentioned earlier: diet, exercise, sleep, stress. We've also moved into a new generation of regenerative therapies in my field. Stem cells, PRP, shockwave therapy. Now we're starting to look at radiofrequency in our laboratory. We're looking at hyperbaric oxygen. Men are looking for ways to cure this condition. They no longer want to take a pill to solve the problem. And so I think that's very important. And many of these new therapies are promising. I think shockwave therapy is very promising, where we have a device that delivers shocks to the penile tissue. We've been doing this. It's like... I got like goosebumps when you said that. Well, but I'll tell you, we've been doing it now for 5 years, and it was invented in 2010. It's actually quite brilliant. If I take your finger and I take a hammer and I hit your finger multiple times, what do you think your finger's gonna do? Your finger's gonna start bringing in new blood vessels and new ways to heal your finger. So before urology, the cardiologists have been doing it for the heart for many years, and they would shock the heart many times and you would see new blood vessels form. It's called neoangiogenesis. Orthopedic surgeons have been doing it for a long period of time. In terms of injury, in terms of healing injury, they'd use shockwave therapy. We are new to the game, but what we see is when you give these shocks, it can potentially improve the blood flow and sexual function in men. And I think the new era could potentially be hyperbaric oxygen therapy and also radiofrequency. Radiofrequency is a way to increase heat within the tissue and improve sexual function as well. So again, I think what you're going to see 5 to 10 years as we move forward is new ways to cure erectile dysfunction. Stem cells potentially have some promise as well, but patients don't want a pill anymore.
One thing we haven't talked directly about, but we've talked about it indirectly, is the role that trauma plays in sexual dysfunction, and trauma in all of its forms. I think I had a partner who was very public again about the fact that the reason why they had sexual dysfunction was because, in their view, because they'd been through a sort of traumatic experience. How often do you see that in your office? How often do you see a patient come to you, man or woman, with some kind of trauma?
We query all men and women if they've had any kind of trauma, sexual or just physical trauma. It doesn't have to be sexual trauma. It can be any kind of physical trauma. I will tell you that most patients don't disclose or not very commonly describe to having it, but they will many times disclose it to the sex therapist, and I'll find out on the back end, to be honest with you. But I think when someone discloses sexual trauma or trauma, it takes more of a relationship and time. And on the first visit, sometimes they're not forthcoming.
What's that you have in front of you on the desk? I've been hesitating talking about this.
This is a penile implant.
Oh gosh.
And yes, that's exactly what it is. And this is a device that was invented in 1973 by a very famous urologist named Dr. Brantley Scott. Brantley Scott, I will have to brag a little bit, was from my institution at Baylor College of Medicine, and this has been around for 51 years. And the penis actually has two bodies sitting on top, and it has the urethra sitting on the bottom. And those two bodies have muscle inside them or casing. And what this device is, the surgery that I perform quite often, where we put these balloons or cylinders into those two bodies and fill them up. There's a small pump that goes into the scrotum, and there's a small reservoir that just holds water, normal saline, that goes behind the pubic bone, typically. When a man squeezes this, he starts filling up these cylinders with water, and it gives him a very rigid, very good erection. When he finishes engaging in sexual activity, he'll press this button here, and it will actually release, and all the fluid will come out of the penile bodies and go back into that reservoir. So theoretically, anyone who's willing to have this surgery, we can cure ED, but it's a surgery.
And what's the consequence and cost of that in terms of sexual experience?
So monetary costs, I would say that in the US, Medicare covers this product, so that's actually quite good. In terms of pleasure, and men report no significant decline in pleasure. If you look at overall satisfaction, it's greater than 92% for patient and partner with the penile prosthesis. So it is a very, it's a game changer. It really is a game changer. Most patients have never heard of it, or most people have never heard of this penile prosthesis. But let's be honest. If you had a bad shoulder, you'd get a prosthetic. If you had a bad hip, you get a prosthetic. It's a prosthetic that fixes an organ. And Stephen, the satisfaction rate is extremely high. But I'll tell you something, you owe me something, because when I brought this on the plane and I went through security, they made me pull this out and explain what this was, and nobody had heard of it. No one had seen this.
Did they believe you?
Yeah, well, I had to explain it, and I had to pump it up and show them, and but I had a little bit of an audience. But yes, but I will tell you this is something that really has revolutionized the way we treat men for erectile dysfunction.
But this is surely like a last-ditch attempt.
It is, because it is a last-ditch attempt. Because if I take it out, no other treatments will ever work again.
Oh, really?
It's the end, right? So if I take it out, no other treatments will work again. So I want you to try every single option before we come to this.
What situation does someone have to be in for you to insert this into their penis?
So remember when I told you that 40% of men at 40, 50% at 50, and most patients will take Viagra, but I told you Viagra is not a cure, it's a Band-Aid. So what's gonna happen? That Viagra is just like that pain pill.
Yeah.
And that pain pill eventually is gonna happen is you can't walk. Well, the same thing happens with ED. Eventually, the meds stop working.
Right.
So once the meds stop working, and then the second level, we use something called penile injections. Some men will use penile injections. Once you've tried everything and nothing works, what are you gonna do?
Okay. So this is like a last.
What are you going to do
okay.
if you still want to get? But if I look at satisfaction rates, if I give men questionnaires for the pill, for the injections, vacuum erection device, for the implant, highest satisfaction, with the implant.
At what point? How, what do you mean?
How satisfied?
From their starting point to...
Right.
Because if I'm starting at a point where I'm completely unable to get an erection,
right.
If anyone helps me get that thing up, my satisfaction is going to be really high.
Right. But let's say you have an erection with a pill, you get an erection with an injection, you get an erection with a vacuum, and you get an erection with this. All four, over time gave you an erection. Which gave you the best erection, and which one were you most satisfied with? This will win.
That's crazy. And can you still ejaculate with this?
Yes. No issues.
Gosh. No. I mean, again, I have tremendous sympathy because it ruins people's lives, right?
It does.
If you can't perform in that way, and it destroys your relationships, and relationships are like the essence of life. So,
but essentially, you're taking someone who can't have sex, who can now have sex again. And some would argue that they can have sex whenever they want, as long as they want, with this device, right? It only goes down when you tell it to go down.
Dr. Mo, we have a closing tradition on this podcast where the last guest leaves a question for the next guest, not knowing who they're going to be leaving it for.
Yeah.
And the question that has been left for you is, have you ever experienced anything that you cannot explain from a position of rational materialism?
I mean, I think so many things in science that we can't explain. So many things that are idiopathic that I have no explanation for. For example, for fertility, which is something we talked about, 40% of men who come to me, our explanation is no explanation. We don't know why you're infertile, right? So obviously that's very uncomfortable for many patients to hear that. But many things in science, I have no explanation for. And many things that I do have an explanation for, we find out 10 years later we're wrong. So I think that's what comes to mind.
What about any personal experiences at all in your life? Spiritual, religious?
Yeah, I'm very spiritual. I'm very religious. Sometimes death. It's hard to explain, hard to understand.
Why?
It's real. I see it every day. We see it what we do at work. I see it personally in my own life. My father passed away at an early age from idiopathic pulmonary fibrosis. It's a condition where your lungs start to scar. It's probably the worst condition you could ask for. And he had to have a lung transplant at 70, so he's pretty young. And he retired at 69. And said, and he worked very hard. He was a general surgeon, solo practice. And he said, one day I'll enjoy. And then at 69, he retires. He's ready to enjoy. At 70, gets idiopathic pulmonary fibrosis. At 70, gets a lung transplant and lives for 5 years with someone else's lungs, which is pretty tough. And his one message was, don't wait till the end, enjoy the ride. I wish I'd enjoyed the ride, because waiting to the end, sometimes there may be no end.
And by that, I interpreted that to mean that he'd worked his whole life very, very hard.
Extremely hard.
And he sort of delayed the gratification to a point that it didn't really come necessarily.
He thought it would come at 70, and he'd enjoy the last 15 years and enjoy. But at 69, he got idiopathic pulmonary fibrosis. At 70, we got a lung transplant. And at 75, he passed away. And I think that if anything I learned was, don't wait to the end, enjoy the ride.
Are you doing that?
I am. Every second I can.
And how do you do that sort of practically when you're so busy?
So I make time, I meditate every morning, I work out every morning, I have my own time to myself, I pray, I'm very religious. I think those are very important things that keep me going. It's God, family, work, patience. I mean, it's an order. My family is extremely important to me, and I make time for them as well. And I think that keeps me grounded.
Dr. Mo, thank you. Thank you for the work you're doing, because as you say in your work, there's a huge proportion of people, couples, men, women, that are suffering in silence, and they are in search of answers. And there's not a lot of people in your friendship group that are necessarily going to know this stuff or even talk about their own experiences with this. So I think it's important to have these kinds of conversations that anyone in the private or comfort of their own home or with their AirPods on can tune into to get a better understanding. If there was a closing message for those people that are suffering in silence in some way, whether they're couples, individuals, what is that closing message to them?
It's okay to suffer from sexual dysfunction. It's normal as we age. And there are many treatment options, good treatment options, that can help you today. And I ask you to seek therapy, raise your hand, tell your doctor you suffer from sexual dysfunction, because they're excellent treatment options.
And if people want to learn more about you and your work, where's the best place for them to find you?
Well, it's my website, drmohitkhera.com, and sexpanhealth.com. I have sexpanhealth.com, where you can learn all the different ways to improve lifestyle modification. I started a nonprofit, I just want you to know, called the Testosterone Project, just so you know that. It's really geared at education, advocacy for testosterone. We're trying to get testosterone approved for women in the United States. I think that's important. We're trying to get testing done as well. We want everyone to be tested for testosterone. It should be norm as well. And we're trying to get it deregulated. So the testosteroneproject.com is a great way to get information as well.
I'll put all of those links below. Dr. Mo, thank you so much for the work that you're doing, and please do keep doing it because it's so incredibly important.
Thank you, Stephen.
Pleasure to talk to you.
Thank you.
Do you know that 80% of New Year's resolutions fail by February? It's because we focus too much on the end goal and we forget the small daily actions that actually move us forward. Those actions that are easy to do are also easy not to do in life. It's easy to save $1, so it's also easy not to. Making one small improvement each day, one tiny step in the right direction, has a big difference over time. And that is the 1% mindset, which is why we created the 1% Diary, a 90-day journal designed to help you stay consistent and focus on the small wins and make real progress over time. It also gives you access to the 1% community, a space where you can stay accountable, motivated, inspired, along with many others on the same journey. We launched the 1% Diary in November and it sold out. So now we're doing a second drop. Join the waitlist at thediary.com and you'll be the first to know as soon as it's back in stock. I'll put the link below.